Hello, I'm Charalambos, Principal Foundation Chair of Cardiovascular Medicine at the University of Oxford, and it is my pleasure to present, together with my colleague, Dr. Kenneth, our article entitled Inflammatory Risk and Cardiovascular Events in Patients Without Obstructive Coronary Artery Disease, the Oxford Risk Factors and Non-Invasive Imaging Study, a multi-center longitudinal cohort study, which has just been published in the Lancet. Heart attacks happen when an atherosclerotic plaque in the wall of a coronary artery ruptures, causing local clot and obstruction of blood flow. However, it is not always the large plaques that can rupture. Small plaques can also break up, causing heart attacks, and one of the major stimuli for the rupture of atherosclerotic plaques is believed to be vascular inflammation. Although this is established knowledge, there is no specific systemic blood biomarker to identify patients with inflamed arteries who are at risk for heart attacks. If we could identify these individuals, we could treat their risk factors more aggressively, or we could even give them anti-inflammatory agents to suppress their vascular inflammation, preventing future heart attacks. Back in 2017, we developed a method that allows measurement of coronary artery inflammation from routine coronary CT angiograms. That method depends on the fact that inflamed coronary arteries secrete inflammatory molecules to the perivascular space. Perivascular fat cells surrounding the artery activate then lipolysis and stall adipogenesis in response to this stimuli, and as a result, they become small and fat-free. This leads to a change in the balance between lipid and water phase in the perivascular space that triggers a shift of the CT attenuation of the perivascular fat towards attenuation of water. We developed a method that captures these changes in the composition of perivascular fat called the fat attenuation indexing and provides a metric of coronary inflammation which is called the fat attenuation index score. Based on this technology, we then developed a cloud-based digital medical device that uses artificial intelligence to segment the perivascular space and extract this hidden information from the perivascular adipose tissue. And by combining it with information about the extent of the coronary atherosclerosis and the patient's clinical risk factors, it provides the percent risk of the individual to experience a fatal cardiac event in the coming years. The algorithms in this digital medical device were originally trained in the USA population, and they were then locked for external validation and clinical deployment. This AI risk model is what we validate in this paper.
The Orphan study is an international registry that aims to include 250,000 patients who had cardiac CT scan as part of the routine clinical care in more than 30 hospitals around the world, and they are followed up for over a decade for clinical events. In this paper, we evaluated the performance of the PHI technology and particularly its ability to predict future cardiac events in the UK population of the Orphan study. 40,000 individuals who underwent routine cardiac CT for investigating coronary artery disease were followed up for a median of 2.7 years after the scan. And we found that more than 80% of these individuals did not have obstructive coronary artery disease. However, despite the absence of obstructive disease, 2/3 of the cardiac deaths and other major adverse cardiac events, or MACE, occurred during the follow-up period in this population. This underlies the major unmet need to develop tools that would allow us to identify the patients at risk by analyzing the hidden information derived from these scans. The PHI technology could be a game changer in cardiovascular prevention if it could identify these patients who are currently missed by the current conventional cardiac CT image analysis because they don't have actionable coronary artery disease. In a nested analysis of 3,300 patients from the Orphan cohort, PHI score was found to predict both cardiac mortality and MACE, even in patients without obstructive coronary artery disease. In this figure, you can see that the distribution of cardiac mortality and MACE over 10-year period stratified by PHI score measured at baseline from the routine cardiac CT scan. Indeed, patients with high PHI score at the highest quartile had 20 times higher risk of cardiac mortality, and nearly 7 times higher risk of MACE over the next 10 years after the scan. And these predictions were maintained even among those with no or minimal coronary atheroma. This suggests that coronary inflammation drives cardiovascular events, and it actually precedes the development of any visible coronary atherosclerosis. We then look into the ability of AI risk model to predict individual patient-level events. Indeed, this model performed very well in predicting the individual risks, as seen by the overlap of the predicted versus observed events in these Kaplan-Meier curves, as well as in the model's calibration curves. This is particularly relevant for those patients without obstructive coronary artery disease, because they are generally reassured by the cardiac care team after they have the scan, and they often remained untreated based on the current clinical guidelines. In a further analysis presented in our paper, the AI risk model can reclassify about 30% patients to a higher risk category and about 10% to a lower risk category. This triggered changes in patient management when deployed in the routine clinical care.
So, in conclusion, in this study, we found that among patients undergoing coronary CT angiography as part of clinical care, the majority of events occur in those who do not have obstructive coronary artery disease. Measuring coronary inflammation from coronary CT angiography using the PHI score predicts fatal and non-fatal cardiac events independently from clinical risk scores and routine coronary CTA interpretation. The AI risk model that combines the PHI score with plaque and the patient's risk factors performs very well in identifying patients at risk of heart attacks, providing an accurate tool for guiding preventive treatments in clinical care. Thank you for your attention.